like urea cycle disorder. So usually in question, this ammonia is the most important things for interpretation, and sometimes organic acid is also given, then it will easy for all. But when the amino acid disorder, if I go back my previous slide, this is the amino acid. So now problem is here, the mother, amino acid is the mother. Okay, so problem is here. So what happened? Ammonia, organic acid is not properly go forward. Okay, so in that case, just
Sorry,
yeah, please.
I'm really sorry, doctor. Your voice is just breaking up over there. It isn't as clear.
Now it's clear.
Yes, it's much better now. Thank you. Apologies for
Okay,
the interruption.
okay, no problem. So from where I should start again?
You mentioned something about the mother.
Okay. So just look at this slide. Amino acid here, the mother. Okay, because if we think amino acid is mother, then ammonia and organic acid is two child of amino acid. Okay, then this ammonia go to this way and organic acid go to this way. Okay, that's all right. So if the problem is with mother, so what happened? This child is not so elevated, usually remain normal or below normal. That means ammonia and organic acid level should not be raised if the problem is with amino acid. Okay, I think it's clear. If
Yes.
okay, if we just look at this slide, this is the amino acid disorder, and the name of this amino acid disorder is maple syrup phenylketonuria homocystinuria. And look at here, ammonia and amino acid all normal or maybe decrease. So just you remember that flow chart and then correlate with the question, and I believe definitely you can, inshallah. Now, this is because sometimes maple syrup urine disease and phenylketonuria is also asked in the question. So nothing in scenario, it can be given that a child associated with some encephalopathy-like feature with maple syrup urine odor and leucine, isoleucine, valine is increased. So if you get this point, you just remember these 2 points: maple syrup urine odor, leucine, isoleucine, valine within 5 days of life increase associated with normal ammonia, because maple syrup urine disease is an amino acidopathy that I said previously in previous slide. So in maple syrup urine disease, if in scenario it is given the child is with encephalopathy like feature, there is some abnormal odor in urine which is some syrup like, and leucine, isoleucine, valine is elevated. Usually in AKP, this is also asked in the question. That's why I said that this is very important for all aspects. So, an ammonia level, you also consider most importantly the ammonia level, and ammonia level is normal. You just straightly go for maple syrup urine disease. Okay. And for phenylketonuria, some important point. In phenylketonuria, there is the abnormal odor. The odor is mousy odor. There is some hypopigmented fair hair with microcephaly, sometimes developmental disability, and phenylalanine level is increased. So I think this is easy to remember this phenylketonuria. Okay. Now something about the this fourth disease, because this is also asked. Already I mentioned many things about this disorder. So if you look in urea cycle disorder, we said that ammonia level too high. Okay, amino acid level is little bit high. Okay, glutamine is high. Sometimes in questions it can be given ammonia level high, glutamine level is also high. Okay, sometimes ammonia cannot be given, but only glutamine level is given. So you should remember this point also, that in urea cycle disorder, glutamine level is high, arginine and citrulline level is decreased. Except arginemia, where arginine level is high, citrullinemia, where citrulline level is high. Otherwise, all urea cycle disorder, arginine, citrulline level decrease associated with high level of glutamine with high ammonia. Okay, and we know about this urea cycle disorder, this OTC. This is a type of urea cycle disorder, and already I mentioned that all metabolic disorder is autosomal recessive. There is some uh, exception. This is OTC, which is X-linked, which is associated with another two important thing. OTC is also associated with respiratory alkalosis and urinary uric acid. So look, sometimes question can be asked this way, that a child presented with encephalopathy like feature like convulsion, alteration of consciousness, and ABG done. ABG is respiratory alkalosis type. Sometimes it can be given directly that the ABG showing respiratory alkalosis. Sometimes it can be interpreted by you by looking the pH, carbon dioxide, bicarbonate. Okay, and urinary uric acid is high. So this is the compact picture of OTC. Okay, so I think this is not clumsy
Okay,
for all.
one issue. Dr. Saurav got disconnected. He has messaged me
Oh,
that.
oh, oh, sorry.
Um,
Yeah, yeah. Thank you, Dr. Asad. Hello, Dr. Saurav. Hello, Dr. Saurav.
Dr.
Okay.
Saurav and Dr. Maya both were thrown out. I mean, uh, hello Maya,
Yeah,
are
sorry.
you
I'm
there?
so sorry. Hi, Asad. Thank you so much. I'm sorry I was just thrown off and I have no idea. Back now, sorry.
Okay, okay, no problem, Dr. Maya and Dr. Saurav. If you want, I can just summarize within few seconds from where you disconnected. Hello.
I think they got disconnected from this slide only.
Okay, okay.
Hi,
So,
sorry, I got disconnected from the previous slide, but it's okay. I'm just going to watch this
okay, no
again, the
problem,
recording.
no problem. So, I think
Yeah,
Dr.
Dr. Shamima, sorry, we got disconnected. Yeah, sorry. I don't know whether internet issue is with me or else I really can't understand. It's very erratic kind of net connection.
Oh, okay, okay. Because here net connection is okay. So maybe it's your side. So no problem. So you, Dr.
Okay,
Saurav, right?
okay.
No, no, no.
Yeah,
You, Dr.
yeah,
Saurav,
yeah. I'm
right?
Dr.
Okay.
Saurabh.
Because I just look at my screen, so I can't see actually who talk with me. So from where you disconnected this maple syrup urine disease slide or just
Yeah, from this slide only. Yes,
okay,
this
okay,
slide
no
only.
problem. I just summarize these things. So maple syrup urine disease, as I said, the urine order is maple syrup, and here associated with increased leucine, isoleucine, and valine. Okay, and as maple syrup urine disease is an amino acidopathy, so here ammonia level is normal. So a child can be present with encephalopathy. There is some abnormal order which is syrup-like, and can you hear me?
Yes.
Okay,
Yeah,
and
I can hear you.
okay, okay, thank you. So sometimes the question, these things can be added in the question. This leucine, isoleucine, and valine is raised. So if you got this type of question and ammonia normal, so this is maple syrup urine disease. This is just two important points about the maple syrup urine disease. Okay. Now about the phenylketonuria. Phenylketonuria, the order is Mauzy order. Usually the hair is a hypopigmented blonde fair hair. This is typical picture for phenylketonuria, microcephaly, learning disability, and phenylalanine level is high. So directly with these points, the question frequently asked. So you can, I believe. So here in urea cycle disorder, in all cases, as I said, in urea cycle disorder, ammonia level is too high. Particularly glutamine level is increased because sometimes in question can be given like this way, that a child present with altered consciousness associated with high glutamine level. Okay, So, and maybe ammonia can be given or not. So in that case, if it is given like this way, encephalopathy with high glutamine, with low arginine and citrulline, you can diagnose this is an urea cycle disorder in broad term. Exception in arginemia, you can understand arginemia means high arginine in blood. So only this case arginine level is high. And in citrullinemia, only this case citrulline level is high. Again, one disconnected, I think. Okay. So this is the point to remember. And another important thing, this OTC, you can find these things a lot. Okay, so you just remember OTC is an X-linked disorder, and sometimes in ABG it can be given that a child with convulsion, there is the ABG done. This is respiratory alkalosis associated with urinary orotic acid. So this is OTC. Just remember these points. If you can remember these points, you can get the answer easily. Okay. Already I said organic acidemia, this is high anion gap metabolic acidosis. Okay. And I also said in organic acidemia, ammonia level is high, but not so, but organic level is high. Okay. So you can find that when a child, because most of the cases is protein metabolism disorder presented with encephalopathy-like feature. So history can be given with encephalopathy associated with sometimes metabolic acidosis, with blood and urinary organic acid level high, with little bit increase of ammonia. So you can diagnose this is a case of organic acidemia. Okay. Now another important point, this is glutaric acid urea. In glutaric acid urea, everyone here? Okay. So in glutaric acid urea, the feature same encephalopathy, dystonia, but important point, sorry, I need to hit just read, that means this point should be focused, this bilateral subdural effusion. This is an important point for this glutaric aciduria, because otherwise everything is normal, like encephalopathy, all present in metabolic disorder, especially the protein metabolic disorder. But if the encephalopathy associated with bilateral subdural effusion, this is the diagnostic point for glutaric aciduria. Got it? Is it clear for all?
Yes, yes, Dr. Shamima. Thank you.
Okay, thank you. Now, just in short, this is the treatment of hyperammonemia. This is protein diet should be restricted as ammonia level is high. Avoid fasting to prevent catabolism, because you know that if fasting occur, then the other metabolic pathway activate, catabolism occur. That's why ammonia level can be increased. That's why avoid fasting. Sometimes glucose infusion can be given, and the sodium benzoate and phenyl acetate is used to eliminate ammonia, and dialysis can be done, either hemodialysis or peritoneal dialysis. So these are the important point for the treatment of hyperammonemia. No need to read a lot of things, just focused on these things, please. Okay. These points, self-mutilatory behavior. What is this self-mutilatory behavior? This is lips biting, finger biting, head banging. This is abnormal behavioral disorder. Okay. And this is called self-mutilatory behavior. So here you can see 3L. But just remember this 3L. What is this? The causes of this self-mutilatory behavior. This is lead toxicity, leishmaniasis, and leprosy. Because sometimes in question it can be given that a child present with abnormal behavior like lips biting, finger biting, head banging. So, and then option can be given. What is the DD? What you think? What is the diagnosis? So you can remember by these 3L. It can be lead toxicity, it can be leishmaniasis, it can be leprosy. Okay. Next. Now, this disease usually associated with hypoglycemia. Is the class is? Do you think the class is boring? or are you
No, Dr.
comfortable?
Shamima, it's absolutely fine. I mean, despite you being not too well, you are taking a really, I mean, speaks volume about you. We are
Okay,
grateful, and
okay,
you can
thank you.
continue as per your
Okay,
comfort.
thank
Thank you.
doctor. Thank you. Back because this metabolic is too tough. I know, I can understand. Uh, okay, so this is hypoglycemia. So what disease usually associated with hypoglycemia? Galactosemia, glycogen storage disorder, fatty acid oxidation disorder. Okay, so this disease usually associated with hypoglycemia. So definitely in galactosemia, not only hypoglycemia, other some specific feature present. Like I also discussed in later on, like there is some vomiting, jaundice, like this. Glycogen storage disorder can be present, doll face, hepatomegaly. Fatty acid oxidation disorder usually present with sudden infant death syndrome in the family, sudden collapse of child. So, but this child always associated with hypoglycemia. This is the important point. Now, in short, and here every point related to exam. Galactosemia. What is the problem? Sometimes question just directly ask, what is this enzyme deficiency in what disease? Just directly ask. And sometimes this easy question we fail to identify due to excitation. Okay, so just remember this thing: galactose 1-phosphate uridyl transferase (GALPUT) deficiency. This is galactosemia. Presentation: usually the child is presented with lethargy, poor
Hello?
feeding. Hello.
Dr. Shamima, can you make that into full screen? I mean, the screen is very small.
Just wait. I try. Oh no.
Put it in slideshow, madam.
It's okay if it's not helping, then it's okay.
Is it okay? Because actually my Microsoft PowerPoint not work, and that's why I'm doing from my Google slide.
Oh.
Should I proceed, or should I consider? That means should I try in another way?
Apu, I think continue. No problem at all
Okay.
with this.
I think you continue, Dr. Shamima. We can see that. Yeah.
Okay. Thank you very much. So in galactosemia, galactose 1-phosphate uridyl transferase deficiency occur, and usually the child present with lethargy, poor feeding, vomiting, diarrhea, some jaundice, which is maybe persistent jaundice, hepatomegaly. I think everyone knows these things, so I don't want to repeat these things. And the important point is cataract. Okay, what is important? The child is hypoglycemia, and Fanconi syndrome is associated with galactosemia. And please look at this: E. coli sepsis, more important point for galactosemia. In case of galactosemia, there is a chance of infection with E. coli. Okay, and if we look at the test investigation, this is clinic test, two tests. One is clinic test, another is clinistics test. So for galactosemia, usually clinic test positive, but clinistics test negative. Here, if you look at this slide, clinistics means S. Here I just added this letter in capital letter. This S. S means sugar. You can remember by this sugar. Sugar means glucose. Okay. So glucose positive in case of clinistics. Otherwise, we know in galactosemia, galactose is present. That's why clinistics, which is specific for sugar, is negative, but clinic test is positive. Okay. And the confirmatory diagnosis by red cell enzyme assay, which is GALPUT, red cell GALPUT level for confirmation.
Dr. Shamima, this is one doubt. This clinistics test is in the urine, no?
Yeah.
Or for the I mean blood. It's for the urine.
Urine.
Yeah, thank
Okay, if you look at this scenario. Sometimes question can be asked this way. An 8-day-old boy came with poor feeding, vomiting, deepening of jaundice, even with phototherapy, clinically icteric, the child with hepatomegaly present, ABG showing metabolic acidosis with hypoglycemia, and conjugated hyperbilirubinemia with CRP raised. What is your diagnosis? So please, anyone give the answer.
Sepsis.
Why sepsis? Can you please explain these things?
Yes. It may be due to, as you mentioned, galactosemia. So patients have hepatomegaly. If patient is icteric
Okay.
and CRP is raised. And also here metabolic acidosis with hypoglycemia.
Okay.
So this is basically E. coli sepsis secondary to galactosemia.
Yes, exactly. Because in sepsis, metabolic acidosis can happen. And as the child, doctor said that hypoglycemia, hyperbilirubinemia, so everything fit with this sepsis. Because in because in exam we are in tense, so we can suddenly just choose this point, glycogen storage disease. So always remember, galactosemia is most important topics for the UK MRCPCH, and they like these topics very much. And another important thing, this E. coli sepsis related to galactosemia. Perfect. Thank you. Next. So I should. Okay, this is in short about the glycogen storage disease. There is a lot of glycogen storage disease. So glycogen storage disease, if you look at here, lots of types, but we should know most importantly type 1A, type 2, and type 5. Okay, so type 1 is called von Gerke, and this is the commonest glycogen storage disease. Sorry, guys, because maybe this font is too short, some may be difficult to visible. If yes, please tell me, because actually there is a, I don't know why my PowerPoint is this Microsoft is not working with me with my this laptop. If you are comfortable, then I proceed.
Thank you.
Sorry, doctor, I can't hear.
At least I am okay, Dr. Shamima.
Okay.